Hi everyone, we're going to get started. This is going to be interactive. If you have your clickers, make sure you press the on button. There should be a blue light on there, okay? And let's get started. So today, I did this lecture I think last year and I added some things. So for objectives, we're going to review the most common rickettsial diseases with a focus on the board review. We're going to review vectors and etiologic agents, pathophysiology, and other entities that present in a similar fashion to rickettsial diseases, okay? Well, we're going to start off with a question just to warm up. Which of the following are considered rickettsial diseases? Lyme, Rocky Mountain spotted fever, Ehrlichia anaplasma, Babesia, or all of the above? So we're going to start. I'm going to stop there, but only 6 of you have clicked so far. All right, let's show what you guys think. All right, so this was the same thing that we got last year, which is why I have this question here. So let's go into that a little bit. So actually, all of these are tick-borne illnesses, but they're not all necessarily rickettsial, okay? So just to keep that in mind. So the answer there was actually Rocky Mountain spotted fever, because in here I kind of outlined why the others aren't rickettsial. So Lyme disease is Borrelia, right? So that's not a rickettsia. Ehrlichia anaplasma, though they're closely related, as you can see by the slide over there, they're not truly rickettsia. And Babesia is a protozoan, so that's not a rickettsia either. So our rickettsial diseases are mainly our Rocky Mountain spotted fever, other spotted group fevers, which we'll look at some of them, and the typhus group. So that's something to keep in mind. Not all that is tick-borne is necessarily rickettsial disease, okay? All right, the next question for you, are ticks the only vectors for rickettsial diseases? And let's start now. Okay, we're picking up. There's 8 of you there. All right, so let's see. What'd you guys pick? So no is actually the correct answer, and let's look into that a little bit more. So there's several vectors for rickettsial disease. Ticks and mites transmit through bites, so because the rickettsia is stored in their salivary glands. Fleas and lice transmit through feces, and that's when they bite you, they also poop, so that's how you get it. So there are several vectors for rickettsial disease. And those who have rotated with me before know that I like a little bit of history, so I kind of put these 3 guys up there so you get a better idea of how the rickettsial diseases were kind of discovered. So here you have Howard Taylor Ricketts. So this guy is an American guy, came around, looked into rickettsial disease, and he figured out that the ticks were vectors for rickettsial disease. Unfortunately, a few days after he made this discovery, he died from a rickettsial disease. And then you have my Brazilian connection in the middle there, that's Henrique da Rocha Lima. And he started studying the same disease, and this was the epidemic typhus that he was studying. He figured out more about the life cycle and the transmission and pathophysiology. And this was his buddy who died of epidemic typhus while investigating the disease. So all in all, not a great thing to have. But that is why the agent for epidemic typhus is actually called Rickettsial prowazekii, because da Rocha Lima decided to name it after these 2 folks, okay? And just to cheer everybody up, a couple of short clips on what ticks actually do and what they look like. So let's do this one. There's no sound. Yeah. Does anybody know how to fiddle with this? Well, that's kind of pointless then. We'll skip along to the next one, which doesn't really need the sound because everything's written on there. But this one's kind of sad, so we'll just do it without the sound. But so you get a perspective of size and what they do. So this is an Ixodes tick. As you can see, the shape and deer tick. This is kind of boring without the sound, I'm sorry. So basically that one female tick is producing all these eggs, and she starts laying all these eggs. And she moves them all. As you can see, this is a process over several days. You see this dent here, that's all from her laying the eggs. And there's the dent. And it goes on and on and on. And she dies. But this is what I wanted you to see, like the perspective. This is compared to a penny, and that's 1,000 little eggs, and this is how big they are. And that's when the new little set of critters come out, and they're all happy to get up on you. The thing with this that you should know is once these little ticks are born, they are not diseased yet. They need 3 blood meals to evolve into an adult tick, and so they need to find those 3 hosts to be able to survive. And so that's why we are not all teeming with rickettsial disease, because not all of these guys survive, okay? Now going into the pathogenesis, so these are gram-negative bacteria. They are obligate intracellular bacteria, and they have a very complex way of actually attaching into the cell. They love endothelial cells. That's what they go for. They induce phagocytosis, but they also cause cell lysis, and then what happens is the cell bursts open and releases all these rickettsia, and they go on to the next cell, and the next cell, and the next cell, okay? Now, if you imagine that they have a predilection for endothelial cells, you're going to have endothelial cell damage, right? And because of that, you're going to have capillary leak. You're going to have increased vascular permeability, and you're going to then subsequently have what? Hypovolemia, right? And you're also going to have edema from capillary leak in other places. So you're going to have your cerebral and lung edema, sometimes hepatic edema too. And so that's why you sometimes see the high LFTs. And you also have a big component of thrombus-mediated vascular occlusion because of all this endothelial cell damage. And that's why a lot of rickettsial diseases have those eschars that you see on the skin. And you know, Rocky Mountain spotted fever, you get the necrotic fingertips. That's because of that. That's how these work, okay? The next 3 slides, I'm not going to go into detail. This is for when you're cramming for the boards and you just want a quick table that tells you this is the agent, this is the tick, this is like the, you know, the mode of transmission and all of that. So, and I'm going to go into some of these through questions during this presentation, okay? So these 2 slides are just, and as you can see, there's tick-transmitted, flea, louse, and mite-transmitted tick disease, rickettsial diseases. This is also the same. This is from our friend Up to Date, just detailing all of the different ones that you can have, okay? But if you want to kind of separate them out geographically, so for the U.S., things to remember. So if you have a question and it's in the U.S., these are the 3 things you're going to think about. So Rocky Mountain, Rickettsia cari, and parkeri. if you look into different places, so Africa, you're going to have Rickettsial africae, okay? In Europe, it's Slovakia. Widespread, you can have the Rocky Mountain spotted fever, the endemic and epidemic typhus, and that's the epidemic is Prowazeki that we kind of talked about, and the typhi. So this is kind of how I separate them out throughout the world, okay? And these next slides are just showing you distribution, and that's kind of just useful to eyeball it and know where different ticks are going to be. But mostly I want you to pay attention to dermacenter here. The dermacenter ticks are the big ones that transmit Rocky Mountain spotted fever. And as you can see, they're in different places in the U.S., but if you kind of sum them up, like the geographic distribution, they're pretty much all over the U.S., okay? But the other thing I want you to pay attention to is that these ticks also transmit tularemia, okay? This is another tick that transmits Rocky Mountain spotted fever, and you can see that that's pretty much all over the U.S. And then we talk about the amblyoma ticks. Those are mostly associated with ehrlichiosis, tularemia, and stari. Stari is the southern tick-associated rash illness, which is a Borrelia, and it's similar to Lyme, but it's not Lyme, okay? And this amblyoma tick here, and this is what we call the Gulf Coast tick because of its distribution, and that transmits our Parkeri. Then we talk about the Ixodes ticks, and those you've probably heard a little more about because they're very associated with Lyme disease, right? But also transmit Anaplasma and Babesia, okay? And you can see the distribution here on the graphs. So when I think about tick diseases, I think of it in terms of a syndromic approach, okay? So a little bit of what we've already talked about. We know they're obligate intracellular bacterium, that they like endothelial cells, that they cause vascular injury, capillary leak, hypovolemia, decreased tissue perfusion, right? And you also, because of the hypovolemia, you're going to have increased ADH secretion, and you're going to have a low sodium. So you think of it as a syndrome, and because all of them are going to have the same systemic symptoms, you're going to have your fever and your headache and your myalgias and your arthralgias and your malaise. You can have a rash, which can be just a maculopapular to vesicles to petechiae. All of them are going to present in that same manner. And the lab abnormalities are going to be similar too. You're going to have your low platelets and your anemia, your low sodium, your LFTs bumping up, and initially you can have a chest x-ray that looks like pulmonary edema. So if the syndrome is the same for all of them, how do you really tell these apart? So that's where location is going to be important. So that's why you need to know those maps, or at least study them for the boards, because you can look them up in real life. And also the different species have certain little peculiarities that we're going to explore through questions pretty soon. So let's talk about the big one, Rocky Mountain spotted fever. We know this is here in the U.S. It's the most common tick-borne disease in the U.S. The agent is Rickettsial rickettsii. And there are several vectors for this, like we saw in those pictures I had put up before. So you have dermacenter ticks and amblyoma ticks and rhiphocephalus ticks. So several different ticks, from dog ticks to wood ticks, that are causing the same disease. So what happens with Rocky Mountain spotted fever? So like I said, the syndromic approach, the syndrome is the same. The symptoms happen 2 days to 2 weeks after your bite. It's usually around a week. The rash can be present in 90% of the cases, but 10% of people don't have a rash. And it comes around the 3rd or 5th day after you get bitten. But the dead giveaway, and pay attention to this, is that the rash starts in the wrists and the ankles and then spreads to the center of the body. And that's why it's a centripetal rash, okay? Lab abnormalities are going to be similar to what we already talked about. Diagnosis is going to be serology, skin biopsy, if somebody will do it, but mainly is your clinical diagnosis, right? Because your serology is not going to be available right then and there, and you need to figure this out when the patient is there, septic, in hypovolemic shock, all right? The big thing, too, is that you have to consider meningococcal disease in your differential diagnosis, because they can present in a similar fashion, and both of these guys are lethal. So you might have to kind of empirically treat for both if they present in a similar fashion, and then figure it out through your LP or your serology or what have you. The treatment for Rocky Mountain Spotted Fever is 5 to 7 days. That's it. It's not 2 weeks. It's not 3 weeks. It's 5 to 7 days of doxycycline, 100 twice a day. If you're pregnant and you can't take the doxycycline, you're going to do chloramphenicol. I know most of you are not familiar with this drug. We don't use it a whole lot, but that's what's recommended as second tier for the pregnant patient in case you run across them. So let's go into questions again. So which are the rickettsial diseases not transmitted by ticks? And I understand you guys are going to have to guess this one because we glossed over those slides, but let's try anyway. All right. All right, I'm going to stop there. I know there's more than 7 of you, but all right, so let's see. We have it all over the map. Most people said C. Okay, so that is not the answer. The answer is actually A. So, and we'll go through all of those that I mentioned in the slide. So actually, Rickettsial acari, which is one that occurs in the U.S., that's rickettsial pox, is transmitted by mouse mites. And Rickettsial felis is because felis is cat, right? So this is from cat fleas. Let's kind of break these down. So rickettsial pox, that happens here in the U.S. It's transmitted by Rickettsial, the agent, is Rickettsial acari. And actually, this was first described in New York City. So what happened was they were doing extermination and housing projects and killing all the mice. And so the little ticks didn't have anyone to prey on, so they started biting the humans. And that's when this was first described. It's also been described in other places in the world, so Korea and Ukraine. Like I said, it's the house mouse mite that transmits this. And the syndromic thing is the same, right? Fevers, myalgias, chills, headache. You can have a red papule at the inoculation site. The rash can be vesicular or maculopapular, but that's the big giveaways that, oh, there was an extermination in the housing project. That's how they're going to present the question to you. This is not lethal. You can get over it, but it's kind of nice to treat someone so they're not having weeks of fever, myalgias, and chills and headaches. The other option that I had on there that was correct is a flea rickettsioses, and that is Rickettsial felis, transmitted by the cat flea. You see the beautiful picture up there. This is mostly South America, Mexico, and Africa, so different location. You're going to have the same symptoms, and it's similar to Ricketsial typhi, which is the endemic typhus, okay? Now, the other one that you should know here in the U.S. is Rickettsial parkeri, okay? This is southern U.S., and they're amblyoma ticks, and these are the Gulf Coast ticks. This is a little different from Rocky Mountain Spotted Fever, because if you saw the description of Rocky Mountain, you didn't hear me talk about an eschar, right? This one does manifest with eschar, and you can also have a maculopapular rash. You have low to moderate fever and arthralgias, and it's much milder than Rocky Mountain Spotted Fever. I always think like Rocky Mountain lethal, some of these others not so much, but it can make you very, very sick, okay? So here in the U.S., you remember acari, parkeri, and Rocky Mountain Spotted Fever. Those are the 3 that you have to remember. Now, what about in other places? So sub-Saharan Africa, the Mediterranean, and India, they have their own rickettsia, and that's Rickettsial connori. And this is also called Bhutanese fever, and it's similar to Rocky Mountain, but less severe. This one, unlike Rocky Mountain, does have an eschar in its presentation, and you can have an abrupt onset. So again, the key here is location, location, location. You have to figure out where these guys are to pick which agent you think is most likely. And I would like to say that here in the U.S. we don't have serology for a lot of these guys that are not from here, okay? African tick bite fever is a favorite of the boards. This occurs in sub-Saharan Africa. The Rickettsial is Rickettsial africae. And the peculiar thing with this guy is that you can have solitary or multiple eschars and inguinal lymphadenopathy. So that's a little different from the other ones in terms that you can have multiple eschars and that regional lymphadenopathy. This is pretty mild illness. I've seen this a couple times, even here in clinic, from people returning from travel. But where they wear is what's going to clue you off. So sub-Saharan Africa, lymphadenopathy, and multiple eschars. Okay. One thing they have reported was, even though this is mild and can resolve on its own, that some long-lasting subacute neuropathy has been reported in association with this, but I don't think that's something they would explore on the boards. Okay. Now, there was that question that we mentioned, Tibola or Debonel. And Tibola has nothing to do with Ebola, but it is a tick-borne lymphadenopathy. That's what it stands for. And Debonel is dermacenter-borne necrosis eschar lymphadenopathy. So Debonel. So both of those are mostly seen in Europe. So that's a giveaway, right? The agent is R. Slovaca, and what's different about this one is that they have a predilection for the head, okay? So you're going to see lesions on the scalp and alopecia around the lesions, plus regional lymphadenopathy. So if you see something that's on the head, then you're going to think Europe, you're going to think winter months, and you're going to think R. Slovaca. Debonel or Tibola, okay? So that's a little different from the other things we've seen. Now let's talk a little bit about epidemic and endemic typhus. So epidemic typhus is the one that killed all the scientists. That is Rickettsial prowazekii. Now this one's it can be transmitted by fleas and lice from flying squirrels, but we know it mostly transmitted from body and head lice. So this is human lice, okay? So if you imagine trenches and crowded conditions and cold, unhygienic environments, that's where you're going to see this, okay? And this can kill, as we know. Many people have given their lives up for science for this guy. You can see it in Africa, South and Central America, okay? Again, acute febrile illness, you can have the rash and all the CNS manifestations, and like I said before, potentially lethal. So this is epidemic typhus, Rickettsial prowazekii, and lice. You remember lice, okay? Now, endemic typhus is also called murine typhus, and murine means mouse-related or rodent-like related. So this is Rickettsial typhi, and this is associated mostly with fleas, so rat, cat, and mouse fleas. So not lice like the other guy. This is fleas and mostly animal fleas. The other one is human lice, right? So this one is actually worldwide, and that's why it's called endemic. And there have been cases even described in Texas. This is, this is not usually fatal, and you can recover from it. But obviously you want to know what's going on. And if you can get treated, you get treated. So let's go to another question. Okay, so this one is a 62-year-old male from North Carolina, coming in late August, has a 3-day history of fevers, myalgia, and rash, and a headache. He works as an electrical lineman. On exam, his fever is up to 39, and he has a faint petechial rash on the wrists and ankles. Which of the following is the most likely diagnosis? Rocky Mountain, ehrlichiosis, anaplasma, babesia, or tularemia? Let's start. This one I gave you a clue before, so there's a dead giveaway in that question. Come on, where's number 7 and 8? Nobody? Okay, let's see if you were paying attention. All right, very good. Okay, so what was the dead giveaway? wrists and ankles, right? So that's the dead giveaway. Very good. So that's Rocky Mountain spotted fever. And we already talked about that, so I'm not going to. All right, so the next one is 30-year-old male from Virginia, presents in July with a 3-day history of fever and rash. He has a fever to 39.3, and he has eschars, right, on the lower extremities. So which of the following is the most likely etiologic agent? Rickettsial rickettsii, Ehrlichia, Rickettsial parkeri, Anaplasma, or Akari? Which do you guys think? All right, I'm going to stop here. So let's see what you guys thought. Oh, my bad. Oh, well. I'm going to give you the answer to this one because I clicked on the wrong thing. But like I said, in the U.S., we have 3 main ones, right? Rocky Mountain, which is Rickettsial rickettsii, Parkeri, or Akari. So I told you guys that Rocky Mountain doesn't usually have eschars, right? And this presentation doesn't look like the sick, ill patient that you see with Rocky Mountain. So it's probably going to be between Parkeri and Akari, right? And the answer is actually Parkeri, and mostly because of the location, all right? Remember I told you about Akari being rickettsial pox and described in New York City and extermination and all that. So that's why that's location and presentation, okay? All right, the next one, hopefully I picked the right button this time, but this is a 45-year-old female in Eastern Europe, comes in December with areas of alopecia. On exam, there are eschars on the scalp and cervical lymphadenopathy. Which of the following is the most likely etiologic agent? Akari, Parkeri, Slovakia, Africae, or Conori? This is something we also talked about. Okay, I'm going to stop there. You click on the poll. Let's see if everyone was paying attention. Very good. Okay, so that's the one I showed you with the scalp, right? Europe, scalp, winter, regional lymphadenopathy. So very good. That is our Slovakia. Very good. All right. And that's the Debonel or Tibola, right? All right. What about this one? 24-year-old female comes back to the U.S. from Zimbabwe. She was on a mission trip. She has fatigue, fever, headaches. You have multiple eschars and inguinal lymphadenopathy. Which is the most likely here? Conori, Parkeri, Slovakia, or Africa? And this is, again, something we talked about. All right, I'm going to stop here. So, very good. This is Rickettsia africae, right, with the African tick bite fever. And the giveaway here was multiple eschars and inguinal lymphadenopathy, right? And the location, of course. All right, same thing. All right, what about this one? So this is a 40-year-old male from New York City, comes in June with fever and myalgias. This one you should all know by now. He states the symptoms started after extermination at the housing project. You notice a red painless papule in his right lower extremity, which is the most likely etiologic agent here. Stop here. Okay, good, good. That's correct. So this is rickettsial pox, right? That's our Akari. So we talked about that, housing project, mouse mites, etc., etc. All right. Now I'm going to have a small, quick section on the imposters, which is everything else that kind of sounds and looks like rickettsial disease but isn't. All right, so let's go through this. Again, this will be questions. So this is a 19-year-old college student brought into the ER for fever, headache, and extreme malaise for 24 hours. While he was waiting to be seen, all these skin lesions start popping up. He goes into shock. He needs intubation and resuscitation. What should be advised to the team who resuscitated the patient? A throat culture, doxy, rifampin, or ampicillin. What do you guys think? Okay, I'm going to stop there. So let's just break this down. So in terms of, the section is called imposter, so it's not rickettsial. But what rickettsial disease does this look like? That looks bad like this. Rocky Mountain spotted fever, right? But that's not what I'm asking you. And so when we go through the presentation, it's very acute, right? Young guy, college student. So this is a two-step question. First, you have to figure out what it is. So this is meningococcus. Very good. And so what do we tell the team that resuscitated the patient? What kind of prophylaxis do they need? Rifampin. Very good. So I just want you to think that any patient that has a petechial rash with altered mental status and all that, obviously you have to think meningococcus. Then you also think rickettsial disease, but just to keep that in your differential, okay? Now what about this guy here? This is a 42-year-old male from Cape Cod, comes in July with fever, headache for 3 days. He, of course, went to Mali a week prior on business. He was only on the city for 2 days, didn't take malaria prophylaxis. By chance, he's also had a splenectomy, but otherwise he's doing great. And he also lived in a wooded area of Cape Cod. He has a dog, and he likes to garden. But he does not recall a tick or insect bite. This blood smear was done due to a suspicion of malaria. The probable source of this infection is which of the following? And let's start this. Okay, I'm going to stop here. Only 4 of you were brave enough to answer this one. Okay. All right, so let's break this down a little bit. There's a lot of red herrings here. So first of all, I want you to take a look at the picture. So what is it that you see in the smear? So, right, very good. So somebody knows that. But you also see these ring forms, right? So the question is confusing because it talks about a trip to Mali, and you think Mali, malaria, and you see these rings. So this is an intra-erythrocytic parasite, right? The Maltese cross is very characteristic for Babesia, right? The only thing, so there's a couple things you need to know. So for Mali, the risk of malaria, if you're there in an urban center for just a few days, is low. And the malaria does not present with this Maltese cross here. So that's one thing to know. And then there's a lot of other red herrings here with the dog and the garden and the Cape Cod and all of that. But the answer here is Babesia, okay? And so this is a protozoan. It is tick-borne, and the deer tick is the responsible vector. And it does occur in Europe, but in the U.S. too. So if you see a case that a patient, it sounds like malaria, everything looks like malaria, but they've never been to an area for malaria, then that's what you pick. You pick Babesia, okay? And here, the big ones that they like to put is Martha's Vineyard, Nantucket, and Cape Cod. They do tend to have a more severe presentation in people who have had a splenectomy or immunocompromise, okay? So that's one of the things that you need to be aware of, how to make that differential, okay? All right, what about this one? A 20-year-old college student had been working in Massachusetts at a Nantucket golf course, mowing the lawn, trimming the bushes during the last 3 weeks of the summer. He developed a painful ulcerated lesion of his hand associated with high fever, painful axillary lymphadenopathy on the same arm, and a dry cough. What was his most likely exposure? So you have disposing of a dead rabbit, cleaning the swimming pool, nicking his hand on a rusty nail, or a bite from a roommate's kitten. All right, I guess it's the 6 of you, huh? Let's see here. What did you guys come up with? Okay, kind of all over the map. Most people voted for bite from a roommate's kitten. Okay, so you guys were kind of looking at Bartonella, I guess. Okay, so let's break this one down. So the correct answer is actually tularemia. So the answer should have been disposing of a dead rabbit, although I do recognize this question is hard. So the thing is, they didn't mention anything about cat bite or anything like that. Of course, the question doesn't, say anything about exposure to anything else. But with Bartonella or cat scratch disease, that progression is a lot slower. You don't really tend to have an ulcer at the site of the scratch or bite, so that's less likely. And then here it also kind of gives you some more symptoms like the dry cough and things like that, so that's supposed to make you think about tularemia. So remember how when I showed you the maps with the ticks, there were ticks that transmitted tularemia? So tularemia is both tick transmission, but also touching the contaminated animals. So if you touch a dead rabbit, that can also transmit, okay? If anything splashes in your eye, that can transmit. So it's also a bioterrorism agent, right? And so, because it is airborne as well. So those are the things that you think about with tularemia. So any disposal of a dead something, that should tip you off. And of course, there are several forms: ulceroglandular, glandular, oculoglandular, pharyngeal, typhoidal, and pneumonic. The pneumonic is like the worst one, which is through the airborne, okay? So I think that was the last case. Oh no, hey, there's one more. I'm sorry, there's a couple more. So these next two cases are kind of go together, and I'm going to try and speed up because I know I'm getting close to time. So this one here is a 43-year-old male visiting southern Missouri on vacation. He comes to see you 7 days after he comes back, and he has a fever, headache, and diffuse myalgias. But physical exam looks okay. When you look at his labs, he has slight leukopenia, with anemia, low platelets, and high AST/ALT. So what is the most appropriate cause of this systemic presentation? And I'm going to be short here. Let me give you just the 7 seconds. Sorry, guys. B, very good. Okay, so just to break this down quickly, what cell is this? This is a monocyte, right? And you see this cluster of things here. This is called a morulae, and this is actually Ehrlichia. So Ehrlichia and Anaplasma are very similar, but they infect different cells, okay? So the monocyte, and that's why it's human monocytic ehrlichiosis, HME. So that is Ehrlichia, okay? The next question is very similar. The only difference is that it is describes a different cell being infected. So the leukocytes, so granulocytic, the leukocytes have the morulae. So here it is Anaplasma, okay? So you'll see those are the differences. So one is monocytic, the other is granulocytic. One is an Ehrlichia, the other is an Anaplasma. One tick is amblyoma for Ehrlichia, Ixodes ticks for Anaplasma. Ehrlichiosis can almost be like a spotless Rocky Mountain spotted fever. And then the morulae are in different cells, right? Monocytes for Ehrlichia and granulocytes for anaplasma. And also the distribution is a little different, this being more in the south central and southeastern United States, and this being more some of the east coast there, okay? And this one you guys might all know. What is this rash? All right, I'm going to stop there. Let's see what you guys picked. Okay, very good. Some people said marginatum, but that's not it. This is supposed to be erythema chronicum migrans, right? So a chronic migrating redness, and that is characteristic of Lyme disease. So I just wanted you guys to know that this rash can be different. It doesn't have to be the typical bullseye with a clearing in the center. It can be just a big old patch of red. So I just wanted you to be, sometimes they have vesicular elements in the middle. I just wanted you guys to be aware that this can present a little bit differently. But yes, this is the Lyme disease rash. And if you see this, you can immediately treat for Lyme disease without actually having to do a whole lot of diagnostics, okay? And oh my gosh, this is the last one, I promise. So this is a 24-year-old woman, sudden onset of fever, a lot of headache, myalgias and arthralgias after returning home from Puerto Rico. She stayed at the resort, swam at the hotel, only ate hotel food, didn't have any new sexual contacts, nothing. She did everything right. One other person she traveled with was sick, but less severe symptoms. You look at her labs, she has a little bit of a leukopenia. Her platelets are not horribly low, and her AST, ALT have bumped up. So here, which do you think is the most likely diagnosis? Give you like 2 more seconds. All right. See what you guys picked here. Very good. You all got this one. So this is dengue fever, right? So Puerto Rico comes back. The whole viral picture. I didn't tell you anything that suggested a tick-borne something, and this is supposed to be a mimicker, so this is dengue fever. The other thing you could think about would be chikungunya, right, which is very similar, but you have more arthralgias in the small joints of the hands. So this was more generalized, so you think dengue, but definitely the differential. And I think this time that's all I have. So this is a flavivirus. It's mosquito-borne, and it's called break-bone fever. The retroorbital headache is very characteristic. And for the most people who are just tourists, they don't have a previous exposure to dengue, but if you are exposed previously and then you get it again, you can have the more severe form, which is the dengue hemorrhagic fever. But that is not very common in the return traveler, unless they've been there several times, okay? Okay, it was the last one. All right, if you guys have any questions, feel free, and I think that's it.